So this is the final video for today's topic. So this is about abnormalities in temperature regulation. So the first one we talk about is fever. So what happened in fever? What happened to our thermoregulation? So fever is an elevation of body temperature due to the changes in the hypothalamic set point of the body core temperature. So in the first slide, I said that the hypothalamus, they set the body temperature. So when you have fever, this set temperature of 37 or 37.5, they are elevated. So when they are elevated, then the body will respond to adjust our core body temperature, reaching this new set point. So the elevation usually in fever, usually they are due to the presence of what we call pyrogens. So pyrogens, they interact with the hypothalamus and then they will cause this elevation of set point of temperature. So pyrogens causing fever. So pyrogens, they can have various origins. So from outside, exogenous, common causes infection or autoimmune medication or malignancy. Or they can also be endogenous. So the most common endogenous pyrogen is what we call interleukin-1 or IL-1. So just briefly, the IL-1 induce COX-2 and prostaglandin, leading to increase in body set temperature by the hypothalamus. So this is the pyrogens that cause a fever. So you don't need to know in detail. I think you covered more during your course 2. So this is just in relation to hypothalamus. So hypothalamus, they interact with the pyrogen. So where is the part of hypothalamus that interact with pyrogen? So it is not the thermoregulation center that we discussed before. Instead, they are at what we call the vascular organ of lamina terminalis. So it is at the ventral medial preoptic area of the hypothalamus, and this area, the VOLT, they contain fever activated neurons. That means if it in contact with pyrogens, then they become activated. So if we look at the structure of the hypothalamus, the VOLT are in this area. So what is a little bit special about VOLT is that VOLT, they don't have blood-brain barrier. So you all know blood-brain barrier usually they protect most of the brain structure from the other things in our body, particularly the things that circulate in the blood. So, all because they don't want to affect the brain function. But VOLT, they can come in contact with the blood because they don't have BBB. So that means they can come in contact with the pyrogens that are in the blood. So this is where the interaction between the hypothalamus and the pyrogen occur. Then you have the increase in temperature set point, then the body will respond accordingly to achieve this new temperature set point. So why do we need increase in temperature during fever? What are the benefits? So increase in core temperature shown to improve survival and also help resolve infection. So it also acts as alert system to activate the immune surveillance system of the body. So usually these are the things that you want when you get fever because of infection or other causes in the body. So increase in temperature basically said there is something wrong with your body. However, as we all know, prolonged or excessively high fever are detrimental due to increased metabolic cost. Because when you want to increase the temperature, naturally you have to increase the metabolic rate. If it's too much, then you can affect other function in the body. So the difference between fever and hyperthermia, even though both are related to increase in temperature, hypothermia is the unregulated elevation of body temperature due to imbalance of heat gain and heat loss. So mostly it due to environment factor. Although sometimes you can have very high fever, then you can have hypothermia. But these are different. So there are no pyrogens involvement or changes in the body temperature set point. So this is the main thing. Fever, you have this increase in the set point. This is fever. Hypothermia, you don't have this change. Okay, so there is fever and hypothermia. Another thing that I want to talk about, things that can occur when you have dysfunction in temperature regulation, is what we call hyperhidrosis. So from the name itself, you can see that there is excessive sweating. So hyperhidrosis. So it is an excessive sweating beyond what the body used for thermoregulation. So it is excessive sweating. So it can be primary or secondary. We'll talk in detail about primary next slide. But for secondary, usually is due to medication or also some disorder such as your diabetes. So when you have diabetes, then you can affect your autonomic function, then it can affect your sweating, Parkinson's disease, and hypothyroidism. So medication is dopamine or selective serotonin reuptake inhibitor. So those are medication that can cause hyperhidrosis. Just to tell you, you don't need to know. I mean, for secondary causes, usually not covered in detail. But primary hyperhidrosis, you need to know. You need to know the criteria and the cause, the underlying pathophysiology. So primary hyperhidrosis, usually sweating for more than 6 months. And the sweating involves the area with high density of acrid glands. So your sweat gland. So your axilla, your palms, and sole of the foot or your face. And the sweating must be bilateral and symmetric so that you know that the problem is overall rather than localized to one part of the body. And then they have basically no sweating or decreased sweating at night. So you know night sweat, there are certain disorders that can cause night sweat. So you need to differentiate the hyperhidrosis, primary hyperhidrosis, and night sweat. Sweating episode lasts at least 7 days. So in 7 days at one time, and you need to have it for more than 6 months. And usually when you first diagnose it, it occurs at the quite young age. So 25 years or younger. And also you have a family history, usually, of primary hyperhidrosis. So this is the criteria that will cause you to suspect a person to have primary hyperhidrosis. And the sweating is so severe that start to impair daily living activity. So this one you to differentiate with someone that just have slightly increased sweating. Usually those, they do not affect daily living activities as much as primary hyperhidrosis. So what is the underlying pathophysiology for primary hyperhidrosis? So we all know sweat, the acrid sweat glands, they are innervated by the cholinergic sympathetic fibers. So in primary hyperhidrosis, you have this hyperactivity of your sympathetic nervous system. So you release a lot of acetylcholine, then you stimulate the muscarinic receptor on your acrid sweat glands, then you become a person that sweats a lot. Your primary hyperhidrosis. So it leads to excessive sweating. So the exact causes we do not know in detail, but it is roughly due to the impaired negative feedback mechanism to the hypothalamus. So hypothalamus is the one that regulates your thermoregulation activity, right? We discussed before. So when you do not have negative feedback, then you keep on sweating because you keep on stimulating the cholinergic function. So those are the criteria and the underlying pathophysiology for primary hyperhidrosis. So there are many other causes of excessive sweating that you need to be aware of, particularly hyperthyroidism and pheochromocytoma. So these two are due to endocrine problem. So thyroid is endocrine hormone pheochromocytoma due to epinephrine and norepinephrine hormones. So when you go through your course 4, you will learn in detail the symptoms of hypothyroidism and pheochromocytoma, and they includes excessive sweating. So you need to be able to differentiate with primary hyperhidrosis. And then we have the situation that can have night sweat. As you know, as I mentioned before, the criteria for primary hyperhidrosis is you don't have night sweats. So when you have lymphoma or tuberculosis, then the patient have severe night sweat. The tuberculosis you covered in detail, right, during your first year. So you know night sweat is one of the main presentation. So this is the thing that help you differentiate. And then the last one is what we call hot flashes during menopause. So this is due to estrogen withdrawal. So this is one of the symptoms of menopause. So you can differentiate with primary hyperhidrosis because menopause obviously those older age, usually around 50 years old and female. So this is a few differential diagnosis of excessive sweating. So the last one that we want to talk about is hypothermia. So basically more heat loss than heat gain, and then cause the body to fail to maintain the temperature homeostasis. It is defined by temperature lower than 35 degrees Celsius. So roughly only 1.5 or 2 degrees Celsius than your normal temperature. So it's not a lot. And mostly, like we mentioned in the heat dissipation video, due to conduction and convection. Very rarely you have hypothermia due to sweating or due to your infrared emission. Usually through conduction and convection, as examples I mentioned before. So the presentation, usually mild hypothermia is between 32 and 35 degrees Celsius. Very non-specific, usually become hungry, nausea, fatigue, and also shivering. Moderate hypothermia is between 28 to 32 degrees. So you start become lethargic and you have cognitive decline, your central nervous system depression, and also decreased reflex. Severe hypothermia below 28 degrees Celsius, then you start to have decreased vital sign and decreased cerebral blood flow, leading to unresponsiveness. So these are different differentiation of hypothermia. And you need to make sure you know that causes of the mechanism of that can cause hypothermia in conduction and convection heat loss setting. So that's all for this lecture. I hope you get a lot of benefits from the 3 videos. Make sure to check all of the other resources that I put in the e-learning guideline page. And also make sure to do the activity as it will help you to evaluate your understanding of this topic. So thank you very much. I will see you next time.